We know that ovarian reserve usually declines rapidly after 35. And then this age group of women also tend to have coexisting gynecological problems and even possibly medical conditions. If there are problems with the sperm, so number one, with the deposition of the sperm itself, meaning if someone has maybe erectile problems, they might experience a problem depositing the sperm in the right location. So there's actually been cases where a 30-year-old's embryo was used for IVF and actually resulted in a live birth.
So, live birth?
Yes.
So the baby was a newborn or 30 years old?
Newborn with 30 years experience.
Hello, welcome to the Med Squad podcast. Now, you've probably heard of or at least watched the acclaimed series, The Handmaid's Tale. I think they have like 6 seasons or something like that. But that's not the point. The point is, it's set in a dystopian future where a group of women are set aside solely for the purpose of surrogacy to the upper class, the rich people, the wealthy ones. Now, of course, the implications of that are negative. But here on the Med Squad podcast, we like to separate fact from fiction and offer hope. We're going to be talking about when wombs wait and the hope after that. So I am joined by a renowned consultant obstetrician and gynecologist, Dr. Mbuche. Hey, how are you?
Fine, thank you, Yafesi.
It's an honor to have you here. It's
Thank
a pleasure
you for having me back.
Yes.
Yes.
Now, I don't know if you've ever watched The Handmaid's Tale.
No, I haven't.
Okay. It might stress you. But we're talking about new beginnings because the unseen struggle here, medically speaking, what is the definition of infertility?
Okay. So medically speaking, infertility is defined as the inability to get pregnant within a certain amount of time. So usually we use the female partner, the age of the female partner. So if the female is less than 35 years, then it's usually 12 months. If the female is more than 35, then we say it's more than 6 months. And the reason why we use a shorter cutoff for the older woman is because we know that ovarian reserve usually declines rapidly after 35. And then this age group of women also tend to have coexisting gynecological problems and even possibly medical conditions. So this 12 months should be of unprotected regular intercourse. Regular intercourse is 2 to 3 times a week. Yes.
Okay.
Yes.
So we'll come to some of the what you mentioned, but actually, in terms of leading causes, what are the most common or leading causes that you see with regard to infertility?
Okay, so infertility is caused by many factors. There are female factors and there are male factors as well that contribute to infertility. So the percentages, female factors are about 40%, male factors another 40%, 30 to 40 thereabout. And then there's combined factors where you have female and male at about 20%, and then another 10% unexplained. We look for a cause, but we just cannot point to one thing. So maybe I can go a bit into detail of what these female and male factors are. So remember, to make a baby, you need an egg and you need a sperm, and then they meet, and then it's a fertilization and a baby happens. So for the male factors, if there are problems with the sperm, so number one, with the deposition of the sperm itself, meaning if someone has maybe erectile problems, they might experience a problem depositing the sperm in the right location, so to speak. And then there are also other causes where males have a complete absence of sperm. So this can come from congenital abnormalities. These are chromosomal abnormalities where there's a problem with the Y chromosome and they just do not make sperm. And then if there is something that prevents the sperm from moving from the testis to the urethra, then there can also be a problem. So someone can be born without maybe an epididymis or something like that, or it could result because of an infection, such things. Infections, childhood infections like mumps, and such things basically. And even when someone has the sperm, the quality of the sperm, so the amount of the sperm, the motility of the sperm, and the morphology. So morphology basically is just, we could loosely define it as maybe the shape, how it looks. It should have a tail and it should have a head and and things like
and
that.
Muscular.
Yes, and it should be able to move to where the egg is. So those are just some of the causes of male infertility. And then for the female causes, once the sperm has been deposited, then it should be able to travel in the genital tract of the female to where the egg is. So number one, you have to have an egg. So if you don't have an egg for whatever reason, for example, last time we talked about PCOS. So if a woman is not ovulating because of PCOS, then there's a problem there. Or sometimes it can result from conditions that prevent the hormones being produced in the brain that then trigger the ovaries for you to produce an egg. So so stress, including emotional stress, excessive exercise like athletes, some eating disorders as well, like anorexia. Those things can prevent a woman from being able to produce an egg every month. And then, of course, there's the age factor, like I had alluded to. So with as the age progresses, then your ovarian reserve also diminishes. Because unlike males, females are born with all their eggs.
Oh, it's limited stock.
Yes, you have limited stock. So at some point it runs out. Okay. And then once the egg has been produced in the ovary, then we expect that the fallopian tube should be able to pick up that egg and transport it towards the uterus. So tubal factors, if you have a problem with your tubes, either resulting from an infection, pelvic inflammatory diseases, from sexually transmitted infections like gonorrhea, chlamydia, or even problems like endometriosis sometimes, because sometimes there's the nodule usually heals with scarring and it just bunches everything up in the pelvis. So tubal factors is also another thing. And then uterine structural abnormalities as well, like fibroids, especially fibroids that are on the inside, in the cavity of the uterus. If a lady has adhesions for whatever reason, I think it's a good place also to mention that infertility can be primary or secondary. Primary means this woman has never had a pregnancy event ever. They've never had a miscarriage. They've never had maybe an intrauterine loss. They've never had a live birth. And then there's secondary infertility, where someone has had a pregnancy event before, and then after that, maybe they want more children and they're unable to become pregnant. So things like adhesions in the uterus that might have resulted from a prior pregnancy event. For example, a miscarriage, you go for an evacuation, then it heals with scarring and things like that. And then there's also absence of some of the structures of the genital tract, like the uterus. There are people who are born without uteruses. Yes. And then it can come as a result of therapeutic interventions. So treatment for certain diseases. Say, for example, you have a cancer of the ovary or a cancer of the uterus and you undergo surgery, then you can have absence of those structures. Just to mention but a few
Those are
of
a few.
the causes. Yes.
It's been quite a comprehensive list.
Yes.
Now, you mentioned kind of an equal percentage in terms of male factors and female factors.
Yes.
So how do you approach couples, or at least emotionally? It's because it's delicate.
Yes.
How do you approach them with regard to infertility when they're facing infertility?
So number one, you have to approach them with a lot of empathy. Try put yourself in their shoes. And then number two, you should involve both the partners so that you're not pointing to one partner and saying that you're the problem or you're the problem. So you investigate and then you have a very open discussion with them. Another thing that is also very important is to pay attention to things like cultural and religious beliefs. Because sometimes someone might come to you, maybe they've had 5 children and they want a 6th child at 42. And in your head, you just cannot fathom. You're saying, but you already have 5 children. Why do you need to? And it's not your place. I mean, if culture dictates that or personal preference, I want to have many children, then it's okay. Or I could have many children like that, but maybe there's a particular sex that I'm looking for. Maybe I only have boys or I only have girls. So you have to place yourself in the mental space of the couple.
Wow.
Yes.
Hey, okay.
Yes.
So I'm going to now, when you come back, we'll be talking about options that are available, because this topic, apart from approaching them emotionally or sensitively, now there might be a reaction. But we'll find out all that when we come back on the Med Squad podcast, as we talk about when wombs wait.
Hey there! Welcome to Zuri Health HQ, where Africa's finest medical minds meet modern care. I'm Yafesi, your host on the Med Squad.
Care is personal. It's not just diagnosis, it's direction. From a cough to managing chronic illness, we listen and we lead.
Every symptom has a story. We listen, explain, and act together.
Nutrition is not just about food. It's fuel, it's healing, it's prevention. We help you eat with purpose, for energy, for recovery, and for lifelong health.
We are not just lab coats, we are detectives, and your blood speaks when we translate.
Your mental health is not a luxury. It's your health, period. Whether it's trauma, depression, anxiety, or even wanting to speak to someone, we are here for you.
At Zuri Health, collaboration is our strongest prescription. We connect expertise across Africa to deliver care that is smart, affordable, and people first.
This is the Med Squad. Real conversations, real health, real people. From your inbox to your bedside, we're with you.
Welcome back to the Med Squad podcast. My name is Yafesi, and I have Dr. Mbuche with me as we talk about when wombs wait. And now we are talking about options and hope. As we get to this, the question we have, having discussed the causes, having discussed, we haven't discussed prevalence.
No, we've not discussed the prevalence. So for the prevalence of infertility, WHO estimates that 1 in 6 couples usually experience infertility at some point in their reproductive career. It's estimated in the high-income countries that it's at about 17.8%. And in the low-income countries, it's about 16.5%. In some parts of Africa, especially in sub-Saharan Africa, the prevalence of infertility has actually been estimated to be as high as 30 to 40%.
It's almost double the other.
Yes.
Wow.
And usually secondary infertility is the biggest cause of infertility in sub-Saharan Africa, especially coming from as a result of tubal factors, because of the high prevalence of pelvic inflammatory disease and some infections like TB. Yes.
Could it also be, I'm just asking, like a result of having many children? Like,
yes,
could it
yes,
be?
yes, yes. So there's a direct correlation between sexual activity and the number of children that you have. So yes, anecdotally, we could say.
Okay,
yes.
Anecdotally, that's
yes,
important. So,
yeah.
so then what options do couples have today when they're facing infertility?
So lucky for the modern woman, nowadays things have changed. It's no longer taboo, and you're not an outcast when you're experiencing difficulties in achieving a pregnancy. Some of the options include IVF. So IVF is in vitro fertilization. In vitro means in the lab. So yes,
vitro is lab.
Yes, in vitro is in the lab.
Okay.
Yes. So basically, it's fertilization that happens in the lab. With that, maybe I could also talk about something called ICSI. ICSI is intracytoplasmic sperm injection. Yes, yes, it's in the process of IVF. So basically, what happens with IVF is you harvest eggs, the oocytes from the lady, and then you harvest the sperm from the male, and then you fertilize them in the lab. You make an embryo, and then you take this embryo and you put it back into the uterus. So it's able to overcome things like if you have a problem with ovulation, because there's a way that you usually do ovulation trigger induction, you can also overcome issues like tubal factors, because you don't need the tube to transport the egg and for the fertilization to happen. And then for the male factors, ICSI, you only need one sperm. So it can overcome some of the male factors, like if you're having a low count of sperm or you're having abnormal sperm or things like that. Yes. So the way the sperm is usually harvested is either, number one, masturbatory. So you get a masturbatory sample at the time when you're getting the egg. Or number two, if you're unable to get an ejaculate from the male for whatever reason, you can actually retrieve it straight from the testis.
Injection.
You use a needle and you aspirate. Yes, from the testis. Yes. So for getting the oocyte, which is the egg from the female, there are different strategies that can be used. Number one, if you have your ovaries, then you can use your own eggs. If you don't have ovaries for whatever reason, you can use your own eggs or you can use donor eggs. The way the egg is got is that number one, you can use just the natural cycle, especially for older women who have a very poor ovarian reserve. And even if you try to push their ovaries by stimulating them to get many eggs, you might not get as many eggs. So usually what you do, you just follow their normal menstrual cycle. You do ultrasounds. And then when the egg gets to a certain size, you do a trigger so that it matures, so that the egg matures, and then you harvest that egg. And then you can use that egg. You can actually pull the eggs from several cycles so that you have a number, and then use those eggs. Number two, another strategy that you can use, especially for women who have polycystic ovarian syndrome, is ovulation induction. So you're not the goal is just to get one egg.
Yeah.
Yes. So you'll give them a drug. These are oral drugs. They are taken by mouth.
Yeah.
And then you follow them up with ultrasounds. And then when the egg gets to a certain size, when it's almost mature, you give them a trigger. The egg matures, and then you harvest that egg. You use an ultrasound and a long needle.
Okay.
And you're able to harvest that egg, and then you can fertilize it.
And she's there throughout this time being monitored until the egg is...
Yes.
Okay.
Yes. A third strategy that you can use is what we call controlled ovarian hyperstimulation. So for this one, you give very high doses of hormones, same as what the brain usually produces during the normal cycle, so that instead of having just one egg, then you have a cohort of many eggs. You can get between maybe 5 and 10 eggs, which is a good response. But this one, usually it's injectables. So you give a daily injection to make the eggs grow, and also to prevent spontaneous ovulation. Because you don't want the woman to ovulate. If they ovulate, then you're not able to collect that oocyte. So you follow them up with ultrasounds. When the eggs get to a certain size, you give the trigger, and then you're supposed to harvest the eggs within a certain number of hours. What happens then now after you've retrieved the eggs? So for the egg retrieval, usually it's done in most places under sedation. The lady will be sedated, and then an ultrasound will be used, and then a long needle will be put in through the vaginal canal directly into the ovary, and you aspirate the eggs. And then once you have your eggs and you have your sperm, then you can do the fertilization in the lab.
Wow.
Yes. So these eggs can be frozen for future use. The sperm can also be frozen for future use. Or the embryo itself, once the baby has been made, the baby itself can be frozen as well for future use.
You said, first of all, this is the first I'm finding that sperm can be frozen. But let's talk about the embryo. How long can an embryo last while frozen?
As of right now, we think forever. Yes. There's actually been cases where a 30-year-old's embryo was used for IVF and actually resulted in a live birth.
Live birth?
Yes.
So the baby was a newborn or 30 years old?
Newborn with 30 years experience.
So they have a pin already and taxes. So in line with that, is that the principle behind surrogacy? Because that is also a kind of a taboo topic. It's one thing to talk about frozen embryos or talk about artificial, not insemination, the IVF.
IVF, yes.
But when it comes to surrogacy, there's a whole other... So how do you explain it to Africans knowing they're sensitive about, where the child came from?
Okay. So surrogacy is a situation where a woman carries a baby for an intended parent or commissioning parent. So it can be done for different reasons. If the woman doesn't have a uterus, like we had said, or if they have structural abnormalities that are preventing them from being able to carry a pregnancy, or they've had more than 3 IVF implantation failures, or if they've had very many miscarriages, recurrent pregnancy loss, which usually we say more than 3, then sometimes surrogacy becomes an option. Yes. There are 2 kinds of surrogacy. There's one called traditional surrogacy. It's not practiced anymore. So traditional surrogacy is where the surrogate contributes the oocyte, contributes the egg. So this is usually done through intrauterine insemination. So intrauterine insemination is where processed concentrated sperm is taken and deposited directly into the uterus. Yes, but it's not practiced anymore, because now it brings a lot of problems with this woman is actually the biological mother of that offspring. Yes, so it's not practiced a lot anymore.
They used to do it in the Old Testament and Egypt and places like that.
Yes. The other kind of surrogacy is where it's called a gestational carrier. So a gestational carrier basically means you have the intended parents giving their gametes to make an embryo, and then the baby is carried by another lady who's not biologically related to that baby. Sometimes you can also use donor gametes. So either a donor oocyte or a donor sperm to make a baby, and then the gestational carrier just carries the baby. Yes.
Do we have to do tests for blood types and things like those for compatibility, if that's a thing?
Yes. So there are some tests that are routinely done for the surrogate mother, because there might be infections that can be transmitted from mother to baby, things like hepatitis, HIV, and such like things. So yes, usually that can happen. And then also for the blood grouping, especially for women who have a negative rhesus, it might also make the situation a bit tricky.
Oh, these are like O negative, A negative.
Yes. If the woman is negative and they are carrying a rhesus positive baby, then it can be a bit of a problem. So of course there is always baseline testing for the gestational carrier.
So are there Kenyan laws supporting surrogacy?
Unfortunately, at the moment, there are really no laws that support surrogacy. It's just that what is used at the moment for surrogacy is just contract law, basically. So it's you get an advocate of the High Court and they draft a contract for you, and that is what is admissible in court or any other place in case of a conflict or something like that.
And that should include things like if you want to be paid or if you're doing it as out of the goodness of your heart.
So there's actually a bill. There's a bill. It's called the Reproductive Health Bill of 2019. This bill was introduced by Susan, the Honorable Susan Kehika. You know her from Nakuru. See, this is very personal for her. Like you are aware, she just had a baby this year and last year through IVF. So this bill, she's the one who introduced it to Parliament. But unfortunately, it didn't make it and it didn't become law. So some of the things that had been mentioned in that bill include the age of the surrogate mother. So they had set it at 21, and then also issues to do with the surrogate having an advocate and the intended parents as well, and the intended parents being the ones to foot the bill for the advocate for the surrogacy. And then also about termination of the contract, that the surrogate mother can terminate the contract before the transfer is done, the transfer of the embryo into the uterus. Yes, but once a transfer has been done, then yes, they cannot choose, for example, to say that they want to terminate that pregnancy unless there are medical implications that it has to be terminated inevitably. And then it also touched on remuneration. So the intended parents are supposed to pay for the antenatal care. So all the expenses incurred during the IVF process, during the antenatal care, during delivery, and possibly even post-delivery complications as well. they are not supposed to be compensated per se, but they should be paid for loss of income during that time when they're pregnant. So basically, that is just some of the things that were on that bill. This bill was actually reintroduced in 2022 by the bad girl herself, Millie. Yes. Also, if you look at Millicent, this bill is also a very personal thing for her because it touches on fertility, and Millie has experienced problems with that. So some of the amendments were that the surrogate should be above 25 and they should have at least one child of their own. Yes.
Okay.
Yes.
I can see how that amendment would, because now thinking about this, you're as the couple, with all those factors, there are so many things to consider. So many. So how do you approach them emotionally? A couple that has chosen surrogacy, that you're preparing them in what way, or what kind of support are you providing them?
So some of the things that we can do for the intended parents is counseling, looking out for things like anxiety, talking to psychiatrists, feelings of guilt, depression, and things like that. And also social support from, say, family or even religious support as well. And then they can also be included in the process of the planning of the, maybe they can be attending the clinics together with the surrogate mother in the birth planning. Once the baby is born, they can be there to do skin to skin and such things. And then also, on the other hand, is the mother who's carrying this baby for someone else. There are also things that go on in their minds. Number one is fear of judgment from the society, because it's a common misconception that women who do this, it's not that they are altruistic. They're doing it for economic advantage, so that they are just paid for it. So there could be those feelings. And then number two could be fears that they might bond with the baby and then the baby is taken away from them. And then, of course, also fears about unfair contracts, maybe not being compensated for commensurate to the time that they've carried this baby. So some of the things that we can do for these women include things like counseling, linking them up with peer support groups of other mothers who've done the surrogate journey as well. And also fair contracts, so that they feel like the compensation was okay. Yes. Yes.
Okay. So when we come back on the Med Squad podcast, as we talk about surrogacy, we'll be looking at the future of reproductive choice. I'm learning quite a bit. You know what to do with the information that you receive on this podcast. We'll talk more about that when we come back. Welcome back to the Med Squad podcast. Now, surrogacy is something that has been around for practically centuries. But right now, we want to talk about the future of reproductive choice. And Dr. Mbuchi, I want to ask if you've seen any change in how women talk about infertility today.
Yes, there is definitely a change, because people are more informed about the choices that they have, and also with advancements in technology and sub-specialization in the healthcare workers. Definitely people are a bit more open to the non-traditional way of getting babies. So definitely there is a shift, but I think more needs to be done.
So I don't know if that's affected by social media and like the openness, but regardless of that, what trends are emerging in reproductive health?
So some of the advancements that are there in reproductive health, of course, IVF being very widely spoken about, and using AI, leveraging on AI during IVF.
Okay.
So yes, AI is helping us to choose the best embryo and the best sperm, so that we increase the chances of getting a positive pregnancy. And then there's also in vitro gametogenesis. So that means it's gametes that are being made in the lab. So gametes is either an egg or a sperm.
Yeah.
There will come a time where you will not need the oocyte or the sperm to make a baby, because now there's research into using stem cells. Yes, stem cells to make gametes and then to make babies.
That was the controversial one. It was pretty controversial.
It's not cloning. It's not like cloning, because maybe cloning might be what is very, very controversial. So it's a bit different.
So they take the stem cells, which now provide the DNA that is needed.
Yes.
And then they create.
They don't make the whole organism from just a single cell.
Yeah.
So they have to make a gamete. So they make an egg and they make an equivalent of an egg or an equivalent of a sperm, and then fertilized and then to make an embryo. So it's not the same as cloning.
Has it been successful?
No, but in the near future, yes, for sure. And then there's also, we've seen successful uterine transplantations. So like in, it should be Sweden, I'm not very sure, but babies have been born, a mother born without a uterus, they get a transplantation of a uterus and they're able to carry a baby to term. There's actually several cases that have, including India. India has actually done successful uterine transplantations. Yes.
Oh, well, in India kind of is the marking scheme for some of these, these trend-setting operations.
Yes.
But what's one, or maybe the most common misconception you've heard about either infertility or surrogacy that you'd love to debunk?
So number one would be that infertility always results from the female partner. So that is not true. The numbers are saying 50-50. So it could be the male, it could be the female. That's one big misconception. The second one is that infertility is irreversible. So infertility is not irreversible. It really just depends on what the cause is. Yes. And we see now there are many, many options, including egg donation. So yes. And then for surrogacy, there is one misconception that the surrogate mother is the real mother of the baby. That's not true. Because the surrogate is not biologically related to that child at all. Yes. Just by them carrying the baby, they do not exchange any genetic material. So the baby still belongs to the intended parents. And also another common misconception is that surrogates do it just for the money. That is not true. These women are benevolent. So they're doing this just out of empathy to help another couple to have a family. Yes. So
okay, when we get back on the Med Squad podcast, we're going to sum this up and land this plane as you learn more about surrogacy on the Med Squad podcast. We'll be right back. Welcome back. This is the Med Squad podcast. We want to reflect on some things and give some final thoughts on surrogacy and infertility. So, Dr. Mbuche, what would you want every woman who is struggling with infertility to hear? What would you want her to hear?
So I would want women struggling with infertility to, number one, talk about it. You just don't know what solution you might find just by talking.
Yeah.
And then number 2, you look for help. So when you're, like we had said, above 35, you've been trying to conceive for 6 months, don't wait too long. Go see your doctor. Try see if there's anything that they will do differently to help you in that journey. And then for 12 months for those below 35.
Okay.
And then number 2 is that you are worthy even without a child. A child does not define your existence. And there are many forms of motherhood, including adoption. Yes.
Okay.
Yes.
Now, just to sum it up, just a quick fair round of just, getting to know you.
Okay.
So your favorite sound in the delivery room?
The cry of a baby.
The cry of a baby.
Yes.
All right. One thing you wish more husbands would do?
Accompany their partners for when they are going to the clinics, especially when they are seeking treatment for infertility.
Okay.
Yes.
All right. Husbands, you had we have work. A reproductive myth that makes you shake your head. Like, hey, where did this come from?
That if you put your legs up after intercourse, it increases your chances of conception.
Oh.
There is nothing like that, really.
Mm-hmm.
Gravity has nothing to do with making a baby.
Oh,
so whether you stand up straight or sit or lie down or...
What?
Yes.
Okay.
Yes.
So which one is harder to explain to in your experience, IVF or surrogacy? To the lay, to an ordinary person, which one is harder for you to explain?
Surrogacy is a bit harder to explain because of a lot of cultural misconceptions as to what a mother really is. So it just doesn't get through to people that someone can carry a baby for another woman. Then how is this your baby if someone else carried this baby for you? At least for conventional IVF where you're using on oocytes, on partner's sperm, and you're able to carry the pregnancy, it's a little bit easier.
Yeah.
Yes.
Okay.
Yes.
And then finally, what message would you have for African women everywhere? In whichever context I guess you choose.
Yes. So African women, to do with fertility and all of this, it's not your fault. It's really not your fault. And it's okay to have emotions. It's okay to feel angry. It's okay to feel frustrated, but look for help.
Yeah.
Yes.
Thank you, Dr. Mbuche, for your expertise and your care and empathy.
Thank you for having me.
Yes. Now for you, as you watch this podcast, motherhood may not always be linear, but it is always noble. If you've received anything that you find useful on this podcast that you want to share with others, please do so. Please share it and also follow us on all our socials at the Med Squad Pod. Follow us and make sure you don't keep this information to yourself. Keep spreading it. We'll see you next time.